Scleroderma is an autoimmune disease characterized by features which include vasculopathy, so blood vessels can become twitchy. So often these patients have something called Raynaud's, where their hands turn white, but also by something called fibrosis, which means tissue becomes hard, fibrotic, like scar tissue. So what often happens, and the characteristic feature of this disease that's externally visible, is hardening of the skin. But that process can be going on internally as well, leading to hardening of other more vital organs like lung or kidney or involvement of the GI tract. We don't know what causes scleroderma, although there are some suspicions of environmental triggers in a susceptible individual. Scleroderma is treated differently in different patients depending on what form of scleroderma they present with. Some patients with scleroderma present with what we call limited disease. They have very little skin involvement, but they may have very prominent vascular features or abdominal upset, things like heartburn. So the vascular features, the Raynaud's, we manage supportively. The heartburn is managed supportively with things like proton pump inhibitors. In patients with limited scleroderma, though, they can also have lung involvement, which would be managed with systemic immunomodulatory therapies. In patients with diffuse scleroderma, where by definition there's broad involvement of skin, so involvement of skin over substantial portions of the body, or even in a patient who we suspect that is what they're evolving to before that's happened, we often treat them with immunomodulatory therapies. And there are a few of them out there which have shown promise, and others that we're looking at in clinical trials. There have been many advances in the treatment of scleroderma in the last 10 to 20 years. Some of these advances are just borrowing advances in other disease areas. So for example, treating the very severe heartburn that afflicts these patients has really evolved tremendously with the use of a class of drugs called proton pump inhibitors, which helps patients with reflux in general, but helps our scleroderma patients specifically. Another area is pulmonary hypertension. That used to be a lethal complication of scleroderma. It also could occur as a primary disease in the absence of scleroderma, and advances in the treatment of pulmonary hypertension has led to improved quality of life in patients with scleroderma as well. Part of the ability of the scleroderma investigative community to bring those drugs to approval has to do with our improved ability to measure outcomes in scleroderma. So it's the science of doing clinical trials and our ability to collaborate across different institutions in uncommon diseases. I'm optimistic that we'll be bringing more drugs to patients in the coming 5 to 10 years.